بسم الله الرحمن الرحيم. السلام عليكم جميعا ورحمه الله وبركاته. شكرا جزيلا لجمعيه العراقيه وجمعيه الرئيسات وتسليح البصره العراقيه ومثلا الدكتور عيسى والدكتور وسام مسؤول التخصص وشكرا لدكتور كتاب وكل تيم ذلك التواجد شكرا جدا. بشرف ان اكون بين اساتذتي وزملائي في هذا المكان اللطيف. اول لقاء مفتوح كان معهم حقيقه قبل 3 سنوات في مستشفى الهيكل. إذا قسم منكم حضر المحاضرة 3 سنوات لإعادة الإفادة، لكن سويت بعض التغييرات وتكون new flavor. But هيكل to find a topic that fits all our subspecialties in our diversity of interest, that fits all is difficult nowadays with all the subspecialties we have in the field. But I hope this topic will meet your interest also. Say that switch to English will be inspired and I love to speak everything just to make things more fluid. So to make the topic more interactive and more practical, I will discuss some cases to speak about prisms in practical life, not only in theory. I'm not preparing you for exams, I'm just letting you know how we can use these tools in our daily practice. This is an example of a 3-year-old girl with intermittent exotropia that started when she was 6 months old and gradually became more constant manifested. She has history of monocular myopia, so her right eye has very large myopia, and she was treated with contact lens on the right eye. She was treated with contact lenses in the right eye, and yes, we do treat contact lenses. We do treat babies with contact lenses occasionally, with very low compliance, but those parents basically get well trained, good training by our optometrist to teach them how to use the contact lens. Long story short, she was okay with contact lens for a few months, but due to compliance issues, we decided to switch to glasses. And we will discuss about the surgical plan in a second. 50 in the right eye and 20/40 in the left eye. Okay, so with this given refraction, this is the cycloplegic refraction. She is -10 in the right eye with +3/4 in the left eye. This is a question, a side question that I will not focus on that, but I know it is a controversial topic here in Iraq. So I would ask your votes, what will be your prescription for the glasses given the above cycloplegic refraction? Are you going to give the full cycloplegic refraction in choice A? Are you going to subtract the right prescription to minimize an isotropia? Are you going to over minus both eyes? Are you going to give plano for the left eye and full correction on the right eye? Or are you going to go with no glasses and just consider patching at this time? So who will vote for the first option? I was hoping to have like an interactive tool in my presentation so you can vote by your phones, but it's not shameful to raise your hands. Who will vote for the first option? Who will give the full correction? No one. Who will give the option B to reduce the anisotropia? You have one hand. 2, 3, 4, Option B, when you over minus both eyes. Who will vote for that? None. Option D, we are going to give plano in the left and full correction in the right. 1, 2, 3, 4, 5. Okay, it's reasonable. When the brain will combine the two images, the two clear images formed by the two aligned eyes to form a single image. Step 3 will be stereopsis, when the brain can utilize some of the disparity among visual characteristics to form a 3D image. Those kids have dense amblyopia. Even if you are unable to check their visual acuity, when you have -10, there is no way this kid can fuse no matter what correction you give them. The goal here is to improve as much as we can from step 1, the simultaneous perception. So don't be shy to give the full correction in kids. They will never complain from diplopia. If you are able to improve their vision to an extent that they can reach to fusion with worth for that,
Good luck with if you see a patient with diplopia, then you can consider fine-tuning your prescription. The rule of 3 diopters of anisotropia and its relationship to diplopia is only relevant when we have acquired anisotropia in adult patients. If you induce monovision, like after cataract surgery or refractive surgery, and the patient may see diplopia from healthy visual function that develops over the first 2 decades of life, but then we induce anisotropia by any refractive issue. Those will complain from from diplopia due to anisoconia from anisotropia, right? But anisotropic amblyopia in children should be corrected fully, okay? So you can consider option 1. You can give full cyclopedia correction. You can consider option C, which will be my option, because the left eye, basically you can go with the plano, because like very weak prescription, or if you are going to correct the mild hyperopia, this is cyclopedic refraction, so we have to subtract the accommodation. We need this kid to accommodate, right? We don't have to paralyze them to fog them with the full cyclopedic correction. So you can go with the plano, or we can go with over minus. So option C will be a good option. Option D will be a good option. Option A, maybe, but never option B. Okay? So this is a side point just to remind you guys that anisotropy in children should be addressed fully and ignore the rule of 3 diopters. Is that clear? Any questions here? Yes, sir. This is a very good question, and this is one of the indications for refractive surgery for those kids. The refractive surgery in children is only considered in 2 situations: when we have such a dense anisotropia like this, or if we have kids with high refractive errors and they have some developmental delays like Down syndrome, autism, any delays that prevent them from the benefit of wearing correction. So those 2 categories of kids can undergo refractive surgery. Not directly, it is complex, it's a very lengthy discussion. Those kids' eyes still growing. This -10 cannot go to plano, and we'll still need to wear glasses, we're gonna still need to wear the patch. The goal of refractive surgery to shrink the anisotropia to improve the quality of visual function. So those families need to understand that the LASIK in those kids is different in indication from adults. We are not eliminating the need for glasses. We are improving the compliance with the glasses. We are improving the treatment of amblyopia. And it is very technically challenging. Even in the United States, there are very few centers who can do general anesthesia in LASIK settings. Plus, the PRK will be preferred over LASIK, because those kids with the rubbing and all the compliance issue will have all the complications of that. Yes, sir. Normally, kids will not give you reliable answers with visual acuity. Up to certain age, like age 3 or 4.
Yeah, age 6 and above.
6 and above, you can try, but they have amblyopia. So if vision is thick like at 2100 or 660 with -3, and you give them -10 and they're still 660, this is not the fault of the prescription. It is their system that cannot see well. So imagine if you have an adult patient who have -10 and you give them -2. They're still unable to function, right? The vision is still blurry. They need the full correction to see well. If there is no anisotropia. Good. Why? Someone mentioned that to me yesterday when I gave lecture to optometrists. They said that we give 2 glasses. I'm not sure about what happens here, but in the US, the glasses are so expensive. It can reach up to $300 for the pair of glasses. So we do not overwhelm families with unneeded glasses. They can function really well. Don't be afraid. You can go with full. Yeah. By the way, I'm sure you saw Dr. Khitam. I did 2 fellowships in pediatric ophthalmology, and this was my first questions I asked my mentors, because I came with this mentality that we have to shrink the anisotropic correction to 3 diopters only, and I said, no, go ahead with full correction. Yes, ma'am. Because the contact lens give you better quality of vision, and we expect the 6-month kiddo will not allow the glasses on their face when they have 6 months. No, we're talking about 6 months kid when they were first diagnosed. So it was 6 months. Now the patient is 3 years old, but it was 6 months when they first noticed, and they tried contact lens when she was 6 months old. So again, accepting the fact that we have a foreign body sitting on the face of a 6-month-old kid who see perfectly well with the left eye, is very hard to convince, right? So the contact lens would be a good option if we train parents how to take care of the contact lenses correctly.
Because we are sunny country, and I think that
It is a big deal. It is a big deal. It is a big deal, yeah. At this point, you have to stick to the glasses, and this is what happened to this patient. Because of the contact lens poor compliance, we have to switch back to the glasses, and we have to consider patching to work on it. But luckily, the vision was not too bad. Okay? Anyways, this was I was expecting this discussion because it's a very controversial topic, but this is not my topic yet. Okay? So the kid was switched to the glasses. Okay? This is her strabismus check. And as we expect, with the four dots, she has no fusion. She is suppressing her right eye at distance and near. Okay? And she has this pattern of exotropia. She has manifest exotropia of 45 prism diopters. I'm not sure if the pointer can work here. It's hard to, anyways. Okay, so it's 45 exotropia in the primary position. That is maintained pretty much good commitance across the board, up and down gaze, right gaze and left gaze. Right? And there is zeros of eye movement restriction, so there is no restriction basically. Okay, so this is a manifest exotropia with left eye fixation and preference. What will be your surgical plan here? Peds fellows, what will be the surgical plan for manifest exotropia with monocular preference? We can do with BLR recession, bilateral rectus recession, or we can do R&R resection and recession of the right eye, which will be the preferred option when you have basic type exotropia. Do resection of the medial rectus and recession of the lateral rectus of the same eye. Anyways, the surgeon, he decides that since the patient has good vision in both eyes, let's do BLR. So they did bilateral rectus recession of 9 millimeters, despite the fact the kid came back in a month for follow-up and she still had exotropia. Okay? It's went down from 45 prism diopters to 20. By the way, I feel echo in the sound. Can you guys hear me well? Sound is good on the back? Okay. Okay, so the orthoptist who examined the baby was the head or the president of American Orthoptic Society. He examined this kiddo and he was shocked that there was an isotropia of 12 prism diopters in the left gaze. Okay? He was afraid what went wrong in the surgery, why we have this huge incompetence. So he came to the surgeon, panicked. The patient's doing well, family are happy, the kid is doing well, but we have an induced isotropia in the left gaze. What will be your thought? What can cause this?
how long after surgery?
A month. Because we are afraid something happened wrong in the surgery. Like what? Slipped rectus muscle. Which eye? Stretch scar. Perfect. Which eye? Right. We did R&R. We did BLR. So both eyes. We did bilateral rectus recession in both eyes. So we expect a slippage or stretch scar happens in the right eye. Okay. So this is the most important thing to rule out. But what would you say about this trace restriction of abduction of this right eye that exactly matches the restriction in the left eye? So we would anticipate limited abduction, correct? And we anticipate some isotropia of the right eye, at least in the primary gaze. What else can happen here? Could be sixth nerve palsy. Why to happen after the surgery? But again, there is no restriction. Did we miss a Duane syndrome? Very unlikely, right? Any clues? Over? We would expect comitant deviation rather than incomitance, right? But we should expect isotropia as well, not exo. Where did you expect isotropia in the primary gaze? Left iso? Left medial rectus muscle?
After you did the bilateral non-rectus recession, there is previously overactive medial rectus muscle.
So how come the medial rectus overact when you have 45 prism exotropia? That's reasonable thinking if we have isotropia, not exotropia. Yeah? Anyways, yes?
عن other eyes.
Not necessarily. We depend on prism diopter measurement, not on the axial length.
And you have jadwal.
So the rectus guidelines for rectus recessions and resections, these tables are based on the preoperative measurement in prism diopters, not with axial length. Okay. To make long story short, this patient, remember, has very high anisometropic myopia of the right eye. This is not the patient in glasses, just like the simulation, that the right eye has very thick prescription. Left eye was planar, okay? And what we saw basically was an artificial isotropia caused by the prismatic effect of a thick minus lens, okay? So since we are going to talk about one of the tricky situations about prisms, let's go back to the very basics. Prisms are refractive objects that basically bend the light toward the base. So when the light hits the prism, it will bend the light toward the base, okay? So the real image will be bent to the base as well, okay? So sometimes I give my own handmade mnemonics to make it easier for a resident to memorize. When we say vision and neonates are blink to light, BTL, think about the light bends toward the base. Okay, so BTL backward, so bend to the base, okay? The real image go to the base as well, but in real life, we are not bothered by, we do not care about the real image because we see the virtual image. So the virtual image will be visualized as shifting up toward the apex, okay? And this is our target. We deal with the virtual image, not with the real image, okay? So virtual image bends toward the apex, and this is the important thing to keep in our mind, okay? This is another example. This eye is viewing this object, and then we introduce a base down prism that will bend the lights toward the base, away from the eye. So for the eye to see the object, it needs to go down, okay? And that will bring the rays to the virtual continuation of these divergent rays of light. So we see the image shifted toward the apex. Clear? Okay. Definition of prism diopter is the units of prisms that are able to bend the light of an object that is 1 meter away from the prism by 1 centimeter. So if you have 15 prism diopters, it will bend the light by 15 centimeters when you hold the object 1 meter apart from the prism. Okay. Angles, sometimes used interchangeably with the prisms, which is slightly confusing, but 1 degree is equal to 2 prism diopters. And there's always keep confusing myself. Is it 1 angle to prism or 1 prism to 2 degrees? But think about it like 1 degree equal to 2 prism diopter or pair of these, pair of diopters, okay? So PD. It is not a linear relationship. It is a trigonometric, which means that every angle, every degree is equal to 2 prism diopters until we reach the 45 degree, okay? So after 45 degrees, the relationship between the angles and the prisms become out of control, okay? The use of that basically is when we do Hirschberg test. When you do Hirschberg test for kids to check strabismus, each millimeter displacement from the center of the cornea will be equivalent to roughly around 2 millimeters. The Bluetooth device is ready to pair. Each millimeter displacement will be equivalent to 7 degrees, and that is equivalent to 15 prism diopters, okay? Any angle more than 45 degrees will be out of proportion to the prismatic correction, to an extent that if we have a deviation that is 90 degrees, right, it will be equal to infinity prisms, all right? We said the clinical application with Hirschberg test, so each millimeter displacement will be equal to 7 degrees, which is 15 prism diopters. So roughly speaking, when you deal with corneas that are roughly around 12 millimeter in diameter, the radius will be 6, and each millimeter displacement from the center will be equal to 15 prism diopters, right? So if you think that the average pupil is 4 millimeter in diameter, the radius is 2. So we have a good landmark between the pupil margin, the center of the pupil, and the limbus. So if we have the light is in the middle between the center and the pupil margin, this is 15 prism diopters of Isotropia. Or if it is all the way at the limbus, then it is 90 prism diopter of Isotropia, right? And if you have it right at the pupil margin, this is 30. If it just past the pupil margin, this is 45. And in between, you have 60. And just before limbus will be 75, okay? Now, this is a very important, diagram for, I never understood it this way until I drew this diagram, actually. So this is normal eyes looking at this certain target, okay? What happened that we have both foveas focused at the certain target to maintain binocular single vision. What happened if we put a prism in front of a normal seeing eye with no strabismus, no issues, the patient can fuse normally, but there is a prism in front of this eye. What happens now is that, as we said, that the light will bend toward the base, correct? So the light will bend toward the point at the temporal retina, correct? Which is registered by the brain to focus on the apple, but here, this point will see the apple shift toward the apex because we are seeing the actual virtual image, not the real image, right? So the virtual image will be seen as shifted toward the apex. We are basically inducing a temporal deviation of the image in the retina that will induce a convergence movement, an isotropic movement of this eye to keep the fovea in focus. So let's go back again. We are here focusing with foveas. We put the prism, we shift it temporally. Then the eye has to rotate to move the cornea nasally to re-register the fovea to the same target and to maintain binocular single vision. This movement, the inward movement of the cornea toward the apex, is basic convergence. So we can test our patients. We can test our patient's convergence amplitude by holding prisms base out, correct? And we can do the same when we put the prism base in. We are going to check the patient's divergence amplitude because we are going to ask the patient to look out in response to the image shift nasally, okay? So just to recap, we are displacing the real image toward the base, as we saw here, correct? And the eye movement will be moving toward the apex. So to check convergence, put the apex toward the nose. To check divergence, put the apex outward, which base in, correct? So this is the normal values for our convergence amplitude. It's very helpful to know these when you test kids with reading difficulty due to convergence insufficiency. So roughly speaking, I have the prism bar, the last three prism between 35 and 45 is our normal convergence amplitude for near. Half of that is our amplitude for distance. And the same 16 prism diopter for distance is equal to our divergent amplitude at near, and half of that is for distance. And of course, as you guys all know, that we have way much less vertical fusion amplitude, right? That's why those who have acquired Fortnite palsy, for example, cannot handle more than 2-3 prism diopters of strabismus because
The Bluetooth device is ready to pair.
because we have very weaker vertical convergence amplitude, okay? We can also apply this concept in checking visual acuity in nonverbal kids with what we call induced tropia test, correct? So naturally speaking, when we have a kid with exotropia, with monocular exotropia like that, like our patient with right eye exotropia, you cover the left eye, the patient will fixate with the right eye, but by the moment you uncover the left eye, she will switch back, correct? This means that she has central vision, she has steady eye, there is no nystagmus, but the moment that you uncover the eye, there will be unmaintained fixation. So we're going to see SUM, okay? But we can also mimic that and stimulate that by our induced tropia test with holding a prism. Same concept applied to checking monofixation syndrome with the 4 prism diopter test for microtropias that we cannot visually see easily in our testing. It is also helpful for testing patients with malingering and functional visual loss or hysterical patients, basically. So this is a simulation of what I just said. Assume this patient has normal left eye. You're holding your toy in your hand and you put the prism base down. Roughly, I choose 16 to 18 prism diopters base down, and we'll come to the base down in a second, why it's base down. So what happens, as we said, the light that is reached the fovea, when the prism hits, it will bend to the base, correct? So this eye will will shift the image underneath the fovea, but that will induce an upward eye movement. So the cornea will go up to maintain the fovea on the target. But we have hearing law that states we have equal and simultaneous innervation to the contralateral elevators. So the right eye will go up as well, and will go down to fixate, to maintain fixation. So what happens here, we put the prism over the left eye, watching the right eye for any vertical drift. When that happens, we can say this left eye has CSM, central steady maintained vision of the left eye under the prism. Let's say the right eye has amblyopia, like an asymptotic amblyopia, no strabismus, the patient is perfectly ortho, but there is suppression scotoma. The kid is still unable to tell us if they see 20/50 or 20/20, right? But we know there is amblyopia there. We put the prism over the right eye. The light will bend below the fovea, but it will fall under the suppression scotoma from the amblyopia. So the eye will not recognize the image shift. There will be no vertical movement, and there will be no movement on the other eye. So this will be CSUM. This is central steady, unmaintained vision of the right eye. So if you are able to elicit this test reliably, even if the patient says no single word, this is a sign the patient has amblyopia of the right eye. Okay? So this is, again, a practical example of how to use prisms in children to tell their visual acuity. And this is the only test, by the way, that you test the visual acuity of the eye under cover. Because normally you cover the right eye, test visual acuity with the left eye. Right? But here we are checking the eye under the prism when you put the prism in. Can you hear me? Okay. Now we describe this model on normal eye. Let's see what happens when we have strabismus, okay? So this is a patient, this is patient right eye, this is left eye. We are looking from above. The patient is looking at the apple. At the same time, we have peripheral vision as well. We don't have only central vision, right? So we have a temporal retina in the right eye that sees field in the left. That is also matched by the nasal retina of the left eye. Okay, so the left hemifield is perceived by the temporal retina here and the nasal retina in the left eye. At the same time, we have right visual field, like this piece of ice cream, that is seen by the nasal retina of the right eye and temporal retina of the left eye. Clear? So let's assume this patient developed acute sixth nerve palsy and developed esotropia. Now the right eye went in, okay? Now there will be confusion about which point in the retina to see which, correct? Let's go back a second. So the fovea in the right eye is focused on the apple. When esotropia happens, this will shift. So the nasal retina will be aligned with the apple, right? And the actual fovea that was here basically will be looking at the cup. Since this is not a fovea, the brain knows that this area is actually temporal part of the retina, right? So what happens here, the patient will develop vision confusion when the fovea of the left eye is looking at the apple, but the fovea, the clearest vision in the right eye, is looking at the cup. And the brain will have confusion because the brain cannot combine two different images. So this is image confusion. You are seeing two different images that cannot be combined. With time, our new visitor here, the nasal retina, thank you so much. The nasal retina will try to volunteer to be our new fovea, the pseudophobia, right? So it wants to create some sort of correspondence with the normal eye. Okay, so the confusion will resolve, but the brain knows that this nasal retina actually sees things in the temporal field, not in the central field, right? So this nasal retina was here nasally that sees things on the right, correct? But now when the nasal retina tried to see the apple, this is what happened. Okay. So the nasal retina will see the apple to the right. That's why when we have esotropia, we have uncrossed diplopia, because you're going to see the new image to the same side of the deviated eye. Let's say it again, it's confusing. Okay, so here again we have fovea looking at the apple, right retina in the temporal retina on the right, nasal retina to the left, looking at the left hemifield, nasal retina in the right with the temporal retina in the left, look to the right hemifield. We have esotropia. Everything get messed up. We have our fovea now is confused because it is now looking at the cup. Now the brain is willing to combine the two different images seen in two different eyes that are looking at two different locations, and the brain will try to see two different objects at the same time, which cannot happen. So this is image confusion. With time, our nasal retina will try to be our new fovea, and will try to look at the same object that the left eye is looking at, which is the apple, right? But the brain knows that this part of the retina is designed to see things in the temporal field, because this is a nasal retina. So when the patient starts seeing two, this will be uncrossed diplopia, because the new image will be at the same side as the crossed eye. Clear? Hopefully. Okay, let's see the exotropia before that. So when you put the prism to correct this esotropia by base out, we are basically redirecting the rays to their origin, right? So the green was here, it will go back to the temporal side, and the yellow will go to the fovea, and the red will go to the nasal side, and the patient will have binocular single vision. Sorry. And we'll see one single apple. And this is the application of prism with acquired strabismus to resolve diplopia. Same thing happened to exotropia. This is the same scheme we just discussed. The patient will develop any reason for esotropia, acute esotropia like stretched scar from after surgery, slipped muscle, partial third nerve palsy. There will be limited AD duction of the right eye, and we have induced exotropia. Okay? And then we have re-registration of our points in the retina. Now, our fovea is looking at the ice cream at this point. So the brain will try to combine two images together and cannot, and because of this is confusion. But with time, our new fovea, which is the temporal point here, try to combine, to focus on the apple to match the fovea to create some sort of correspondence, right? But this area in the brain is registered to see images in the left field, because this is a temporal retina, right? So this patient will see crossed diplopia, okay? Crossed diplopia, because the temporal retina is now taking action to be in focus, to be the fovea, but this temporal retina sees objects only in the left or the nasal field, correct? So when we put the prisms here, we're going to point our prism base in or apex out. So the apex will be out, and we will re-register everything. And the patient, the same yellow light will focus on the apples, and we have single vision, right? Salt? Sorry. So basically, you don't have to rethink this every time. It's easy just to think that exotropia gives you crossed diplopia. Think about XX. So exotropia XT give you a crossed diplopia, right? While esotropia give you uncrossed diplopia. And the best way to test that is with Worth 4 dot test, correct? We put the red-green glasses, red over the right, always RR, and ask the patients to tell you how many circles they can see, how many circles, right? What I typically do for even like 1-year-old kid, I bring their finger and try to touch the white circle, because this is the circle I am sure that the kid can see with either the right or the left, right? I don't want them to count. I don't want them to tell me green or red. They will just touch the circles that they can see. If they touch only 2, this means they have left eye suppression. If they touch 3 only, this is right eye suppression. If they try to touch 5, this is diplopia. But if they can tell, you're going to see cross diplopia as the right circles will be seen to the left of the patient, And with the uncrossed diplopia, you're going to see the the red circles to the right of the green, correct? Okay. So prisms and strabismus in general, we use them in Kremiski test to verify our Hirschberg measurements. We use them at PACT, which stands for, what does PACT mean? Resident in the back. Prism alternate cover test, perfect. What is SPCT? أنتوا تعرفون بيت الشباب. Simultaneous prism cover test, which is used for? This is a different lecture, inshallah. This is to measure the tropia only component of strabismus. PACT, prism alternate cover test, measures the tropia and phoria all together without differentiation. SPCT is the test that we measure the tropia, the manifest component of strabismus only. Okay? But no matter what purpose you use the prisms for, always keep the apex pointed toward the deviation. Right? So the base will be in reverse. We use it to relieve diplopia, so we use it to diagnose strabismus, to measure strabismus. We use it to relieve diplopia. By the way, just like a fun fact come to my mind, I noticed that we, especially Iraqis, we are like abroad, we apply a very famous Arabic rule that التقاء الساكنين يكسر أولهما تمام؟ لم يكن الذين two ساكنين يلتقون نكسر الأول فنقول سترابزمس أو سكوينت أو سكرين no screen strabismus تعلمتها بالخطأ بعد ما يعني. Okay, so to relieve diplopia, so in a symptomatic patient we put the prisms to relieve their symptoms. Correct abnormal head posture. So when you have a patient with, acquired ocular torticollis, we can correct them by removing the image toward the apex. That's a different, will come in the discussion here. Assess the likelihood of diplopia after strabismus surgery. So if you are planning for surgical correction for long-standing strabismus, we can use the prisms for what we call the Prism adaptation test, which we can dispense basically frenal prisms, stick-on prisms for patients to see if they can see diplopia after a while or not. In my practice, in the way that I was trained, this is rarely seen, so we do not spend much time on testing that because we almost never saw a patient with diplopia after surgery. This is our practice. I'm not sure if you had something different. You do? That lasts for a long time? Oh, okay, interesting. Because there was one case reported recently in APOS meeting. A physician, I think from Israel, mentioned that her devastation with chronic diplopia after surgery. And she was like reviewing all the literature. This is very rare and we never see it. It's like interesting. If you like, go ahead, but I mean, in our hands. That's right. Anyways, this is the use of prism. It's not necessarily, required. Vision therapy, we are very skeptic. We as pediatric ophthalmologists, when we hear about vision therapy, the only use of vision therapy in the world of optometry that has enough evidence-based medicine behind it is the use of vision therapy in convergence insufficiency only. Although many optometrists in the US try to sell different types of vision therapy with very expensive price tag, but none have any evidence to support that. Anyways, important fact about prisms is that we have different positions that differs basically from the type of the prism. We use plastic prisms, whether the prism bars or the loose prisms in our clinics. And these are prisms that are calibrated and designed in the position of minimum deviation, which is basically when the angle of incidence is equal to the angle of emergence. So when they calibrate the prism, this is 10 prism diopter, basically is when the light hit the prism with a certain angle, it will diverge from the prism, the other side of the prism, with a similar angle. Okay? The other way of calibrating prisms is with the Prentice position, which is basically we allow the incident ray to be the surface of the prisms, and this will give us more deviation. Okay? To avoid confusion, luckily we do not deal with the glass prisms anymore. What we have in our clinics are just plastic prisms, okay? I just put the GP mnemonic to make you less confused. So Prentice is basically for glass, and ignore it. The practical ones, the minimum, the position of minimum deviation. How is that important? So when you check a patient, and if you want to be truly careful to keep the prism in the angle of minimum deviation, you have to make sure that the visual axis angle with the back of the prism is equal to the angle of deviation that's seen behind the front of the surface, which is in real life, it's very challenging, right? Luckily, the closest position, the closest correct position for this is the frontal plane position, which means that you hold the back of the prism parallel to the frontal plane, regardless where the eye is, okay? So in the past, what's the clinical application of that? When I have a patient with large exotropia, I try to put the back of the prism tilted this way, so the visual axis will be perpendicular to the back of the prism. This is not correct. The correct position is to keep the back of the prism parallel to the frontal plane, regardless of the position of the eye, and make sure that the patient is looking through the prism when you do the cover test. So basically, I put my patch on the patient's eye and hold the prism until he can see the target, and then go ahead and do the cover test to make sure that you are seeing the actual deviation. So again, the goal is to keep the back of the prism parallel to the frontal plane of the forehead. Because if we put it in a way that is perpendicular to the visual axis, it will give us way much mistaken degree. For example, if we are testing a patient with 40 prism diopter here, the actual measurement will be around 41 with the frontal plane, but it can be as high as 72 when you hold it in the wrong Prentice position, okay? So the take-home message from here, make sure that when you measure strabismus, شباب ممكن نوصل الميكروفون شوي؟ ممكن نوصل الميكروفون شوية؟ الصوت جدا عالي. Okay, so keep your prisms in the frontal plane in which the back of the prism is parallel to the frontal bone. Clear? Any questions? Okay. We spoke about the frontal plane. When we try to measure big deviation, you cannot stack prisms back to back in the same direction. If you put a 10 prism diopter base in over a 40 prism diopter base in, it will not be 50. It will be 100, roughly, because you cannot predict the interaction between the two surfaces of the prism. So if you take this interface and magnify it, there is additional bend happens that will give you false measurement. And instead, you can split prisms. We can stack prisms vertical and horizontal, although it's not very accurate, but it is less confusing than stacking two horizontals or two verticals. Let's say you have a patient with XT and hyper. You can put base in and base down at the same time on the same eye. That's okay. But you cannot do two base ins or two base downs. You have to split. So when you have larger deviation, we use the split. This is a very fancy loose prism called push-up prisms. They come with a magnet in each prism that sits on a metallic, like small table that the patient will hold. So you can play with the prisms vertically and horizontally without getting confused with occupying your both hands. So you can still have free hand for the paddle or to cover, and the prisms will sit by themselves on this magnetic plate. Okay. Remember to tilt the head, to tilt the prism when you tilt the head. So when you check like the 3-step test with superior oblique palsy, make sure when the patient is tilted to the right, you hold the prism also tilted, right? You don't want the prism to be vertical at 90 degrees, okay? Beware about primary versus secondary deviation. When we have patients with paralytic strabismus or with neurogenic strabismus or like restrictive strabismus like thyroid eye disease or so, make sure that you put the prism over the eye with deviation. I'm pretty sure they're all familiar with this drawing that came from Kansky, I think, that this patient has right 6th nerve palsy and right esotropia, and he is fixing with the left eye. So when you cover the right eye, you can see there is small esotropia here. But when we force the patient to fixate with this paralytic eye, the brain needs to stimulate the weak lateral rectus so hard to bring the eye to the midline. And because we have hearing low, there will be simultaneous innervation to the medial rectus muscle of the good eye that will induce much more ESO than the primary deviation. So if we hold the prism by mistake here on the normal eye, when you check this 6th nerve palsy patient, you will end with very large deviation, which is not the true deviation. This is the secondary deviation. Okay, so make sure to hold the prism over the normal, the eye that has the deviation itself. Whether it is thyroid eye disease, whether it is orbital fracture, whether it is 6th nerve palsy, whatever it is. The exception for that when you deal with basically with non-paralytic strabismus, like with kids who have alternating strabismus, we can switch prisms freely. And this is also a diagnostic tool. If you have no idea what type of strabismus you're dealing with, you can tell the difference between the measurement when you switch prisms. It is mostly clear because there will be restriction with eye movement, but just like quick tip, always hold the prism over the deviated eye. Frontal prism is a very friendly way of dispensing and testing high prisms, because obviously you cannot dispense glasses with 40 prism diopters, but if we can stick a frontal prism over the glasses. And when you Google frontal prisms, the first image come to you is with Hillary Clinton when she had concussion when she was Secretary of State. And we can tell which eye is the problematic eye and what type of deviation was that, because she has a base out prism over her left eye because she developed slight 6th nerve paresis from the concussion. The reason we can tell that for the resident and trainees, that you can tell from the displacement of the temple, so you can see the cheek come here and shift inward, right? So this is a base out prismatic effect of the frontal prism. She doesn't have money to get the full ground prism, so she had like pay $25 for the prism. Okay, we use prisms in all optical instruments, basically slit lamp. We use them as reflectors. We use their total internal reflection property. They are more flexible than mirrors. We use them in slit lamp, tonometers, and keratometers. Okay? Now, the whole discussion brought us here is basically the prismatic effect of lenses. So we spent a lot of time discussing the basic of prisms. Now let's go back to the prismatic effect. Thick lenses are basically prisms that are held either apex to apex in case of concave lens, or thick prisms held base to base in case of thick plus lens, right? So let's get this simulation here. A patient is wearing a thick plus lens, okay? And the eye is ortho, looking through the optical center of the lens, okay? Let's say that this patient has esotropia, okay? This is the right eye. We are looking from above, this is the right eye. Now the right eye goes inward toward the nose, right? So it will be this, the visual axis will be far away from the optical center of the lens, which means that we are holding a prism in the front of the eye. In which direction? Base out, perfect. And we actually measure esotropia by holding prisms base out, correct? Which is a good thing. So the glasses basically hides some of the thick lens basically hides some of the esotropia by adding some base out prism, correct? On the other hand, if the eye was exotropic, right, it will be decentered from the optical center of the thick lens, as if we are holding a base in prism, which naturally used to test and measure the exotropia, right? So this means that the thick plus lenses are good stuff. It will hide the strabismus, because it will give prismatic effect in favor of the strabismus, in the same direction as the strabismus. But because of the magnification effect of the thick plus lenses, it will cosmetically magnify the appearance of the drifted eye. Okay? So again, from optical standpoint, high plus is good stuff. It will, as a positive person, it will also collaborate and hide the strabismus. But because of the high magnification effect, it will make the strabismus worse. And probably you saw when you come up with, you have a patient with like dense amblyopia with sensory exotropia or so, they were like plus 10. It's obvious they have large deviation, but the actual deviation is much less. Let's go on the other hand when you have high minus lens. We said minus lenses are apex to apex, right? Prisms. So when the eye is ortho looking through the optical center, there is no prismatic effect. But when the eye develops esotropia, we said the esotropia is measured by base out prism. But this is base in effect, right? The same thing applied when this eye developed exotropia.